Hello, everybody. This is John White. I'm the Director of the Health IT Portfolio at the Agency for Healthcare Research and Quality. And I'd like to thank you for taking the time to join us for today's teleconference on ePrescribing for Health IT. The Agency for Healthcare Research and Quality is an agency within Health and Human Services, part of the U.S. federal government. And we focus on our mission of improving the quality of healthcare for all Americans. In particular, Congress has asked us to focus on health IT as a means to improve the quality and safety of care that gets delivered. And of particular interest to us over the past couple of years has been electronic prescribing. In addition to our various programs, we work very closely with our federal partners. And in this particular case, we have worked with the Centers for Medicare and Medicaid Services, CMS, to conduct a series of pilot projects that focus on electronic prescribing standards that are required for the Medicare Modernization Act. I'm not going to get into details of those as our presenters are going to be doing that today. So instead, let me introduce to you our outstanding panel, which we have with us today. You know, at ARC, we work with a great many talented individuals, but I'll tell you, a nicer and smarter group I have not come across, so it's my great pleasure to introduce these folks to you today. Speaking to you first will be Shelley Woolley, Principal at Woolley & Associates. Shelley is an experienced healthcare strategist that has served in many of the industry's most innovative and leading organizations promoting the use of health information technology for improving the way care is delivered in this country. Shelley is currently the Principal Consultant for Woolley & Associates, an independent consulting organization focused on strategic business development. Prior to establishing her consulting company, Ms. Woolley was the Senior Vice President and Communications Officer for RX Hub, the nationwide electronic prescription drug information exchange. Ms. Woolley has more than 20 years of leadership management experience in the healthcare industry. Ms. Woolley received a Master's of Science and Master's of Public Health from the University of Minnesota School of Public Health. She was an assistant professor at Towson State University in Maryland in the Health Sciences Division and continues to present and educate at national healthcare conferences. Also presenting at today's conference is Douglas S. Bell, MD, PhD. Doug is a general internist and a researcher focusing on design and evaluation of health information technology. He is an assistant professor of medicine at UCLA and a research scientist at RAND. In addition to internal medicine training and a PhD in health services research, Dr. Bell completed a 3-year medical informatics fellowship in the Harvard-MIT Health Sciences and Technology program funded by the National Library of Medicine. Dr. Bell's primary research has been in 2 areas, electronic prescribing systems and online physician education. In electronic prescribing, Dr. Bell led the development of expert panel recommendations for ePrescribing features, and in a field study showed that these features varied substantially among commercial systems. This work helped set the stage for the work of the Certification Commission for Health Information Technology. Dr. Bell also led one of the pilot studies called for in the Medicare Modernization Act to evaluate advanced electronic prescribing standards. And finally, we're also joined by Mike Bordelin. Mike is currently the Executive Vice President of Product Development for Talist Incorporated, where he's developing technology systems that enable remote dispensing models for the long-term care and prison markets. Bordelin, who is based in Dallas, has held key leadership roles in the advancement of technology to improve quality of care and efficiency for long-term care for over 8 years. As Vice President, Research and Development for Achieve Healthcare Technologies, he led the National Council of Prescription Drug Plans, NCPDP's, 50-member long-term care task group on electronic health records and ePrescribing standards. He was the principal investigator on a $1.5 million CMS and ARC grant to study long-term care ePrescribing and led development of the first standards-based ePrescribing implementation. He previously led the firm's product development unit, which created web-based long-term care electronic health records and financial systems. And again, I just want to reiterate that working with these folks over the past years has been an extraordinary pleasure, and I'm very excited that they have the chance to present their work to you today. And with that, I will turn it over to Shelley Woolley.
Well, thank you. It's a pleasure to talk with you all today and to share some of the insights on how ePrescribing pilot efforts will help us understand and overcome some of the key challenges in moving us forward in an environment where adoption is accelerated and patients, providers, and payers and all the stakeholders in the prescribing industry achieve indisputable benefit and value. The goal of ePrescribing is really for a clinician to be able to prescribe a formulary-compliant drug eliminate handwriting errors and the confusion regarding medication names and dosages, preventing drug interactions, and eliminating the estimated 150 million a year callbacks from pharmacies due to errors, as well as providing a means for transferring a prescription to a patient's chosen pharmacy. The passage of the Medicare Prescription Drug Improvement and Modernization Act of 2003, which I'll now refer to as MMA, for the first time clearly defines the E in ePrescribing, and for the first time describes a specific ePrescribing program. The MMA stipulates that any party that submits electronic transactions under this program for Medicare-covered drugs prescribed for Medicare-eligible individuals must be in accordance with uniform standards that are announced by the Secretary of Health and Human Services. When the Department of Health and Human Services promulgated rules proposing the standards for electronic prescribing, the rules indicated that the industry had identified already 3 well-accepted standards and felt that they were ready for immediate implementation. These are referred to as the foundation standards. In order for true ePrescribing to be realized, that there were several other areas in which standards had not yet been developed or were needed to be improved upon, and thus the rule proposed for 6 what we call initial standards for the pilot testing. This slide identifies both the 3 foundation standards, including NCPDP telecommunications standard, as well as the ANSI X12 270 271 for eligibility, and NCPDP script for new prescription, change, renewal, and cancellation messages. And the 6 initial standards include NCPDP Formulary and Benefits Standard, and the NCPDP script medication history, initially developed by RxHub and submitted to the NCP for certification and accreditation, as well as NCPDP script field status notification, structured and codified SIG, prior authorization, and Rx norm. Each of the 5 grantees that were participating in ePrescribing pilots were expected to test all 6 initial standards, but they were given vast flexibility and latitude in testing various other outcomes of ePrescribing, including prescriber uptake and satisfaction, things like workflow changes, impact on callbacks between physicians, pharmacies, and PBMs or payers, the use of ePrescribing functions, including medication history, change in fill status, use of on-formulary or generic medications, and overall the impact on medication errors. A brief description of the recommended focus for each of the testing of the 6 standards includes the following. I know this is a pretty wordy slide, but I'll kind of take you through it. Medication history was to provide a uniform means for prescribers and dispensers and payers to communicate an accurate, up-to-date list of drugs that had been dispensed to a patient, regardless of who the patient saw, which physician they saw, or what pharmacy they visited. The testing requirement was to determine the readiness of the NCPDP medication history standard. Formulary and Benefits provides prescribers with information about a patient's drug coverage and benefits at the point of care. It includes formulary information, lower cost alternatives, indications that there needs to be prior authorization or step therapy, as well as some copay and cost information. And the testing requirement for this standard was to determine if it should be adopted as a standard. Full status notification notifies the prescribers after a patient has picked up a prescribed medication from the pharmacy. Testing requirements for this were to assess the business value and the clinical utility of this standard. Prior authorization offers a streamlined electronic process to communicate the need for prior authorization directly to the prescriber and allows the prescriber to send the requirement information along with the prescription for efficient fulfillment. The testing requirements were to determine the functionality of the new versions of the ANSI X12, 275, 278 with the HL7 attachment. Structured and codified SIG includes patient instructions for taking medications. For example, take 1 to 2 tablets by mouth every 3 to 4 hours as needed. Currently, there is no standardized format or vocabulary for SIGs. And finally, RX norm, which provides a standardized vocabulary for name, dose, and form of available drugs. Today, there's a multitude of databases for drug names, forms, and dosages, each using slightly different variations of these data elements. So the testing requirements were to determine whether the RX norm terminology translates to NDC for new prescriptions, changes, and renewals. In addition to each of the 5 pilots were to determine overall which of the 6 initial standards are functional and which were not, and the extent to which these 6 were interoperable with the foundation standards and one another, and to document the benefits and the challenges they experienced in implementing the standards in various settings. And you'll hear from 2 of the grantees that will tell you about the differences in the makeup of their pilots. Besides the standards themselves, as I said, the pilots were to report on other outcomes as a result of implementing these standards. And ePrescribing in general, including, again, prescriber uptake and user satisfaction, workflow changes, impact on administrative efficiencies, impact on medication errors. These are some examples. These findings will be discussed a little bit today and also more thoroughly in part 3 of the series that will occur sometime in the very near future. What was our methodology? Well, as a participant on the evaluation team, I'm able to report to you that we did conduct a very thorough evaluation of each of the pilot's testing activities in the form of first document review. This included each of the pilot's original grant proposal, so we could identify what the pilots said they were going to test and how they were going to test the standards. Then we had structured telephone calls that allowed us to determine the current status of their projects and discussions regarding any of the preliminary results. We had 1 day, full day, on-site visit, which allowed us to listen to some of the key participants present their approach and observations, as well as to collect information that would help assess their testing methods and their evaluation approaches. And finally, we did key informant interviews after the site visits were completed that served to validate the information that was gathered during the site visits from industry experts that were already working on various aspects of ePrescribing. So what did we find? Having analyzed the 5 pilot sites' findings in the context of their characteristic and testing methods, we made the following recommendations on the initial standards. For medication history, the standard was relatively mature and widely adopted by the prescribing industry, and it was also shown to be useful in preventing medication errors, as well as understanding medication management compliance. It was recommended that the standard is ready for implementation. However, additional training and education must occur to make prescribers aware that this functionality exists and that multiple sources of medication history information must be reconciled and presented to the prescriber in an effective manner if we're to see increased adoption. For formulary and benefits, it was determined to successfully support the transfer of the required information, and it was recommended as ready for prime time. But like medication history standard, there are several important implementation issues that still need to be addressed. Prescription fill status notification does adequately support the activities of a pharmacy sending messages to the prescriber regarding the status of a prescription, and thus was recommended for implementation. However, the pilots found that there may be little prescriber demand for this capability at this time. Medication history is, what's not ready? The 3 of the 6 initial standards are not recommended for implementation as part of MMA, ePrescribing program, and they include prior authorization, structured and codified SIG, and RX norm. All of them were found to have potential to create efficiencies and help streamline the process, but they're still in the need for additional development and testing. Implementation of ePrescribing has the potential to dramatically change prescriber and pharmacy workflow, and you'll hear about some of those workflow in the upcoming session. often with positive impacts, but some negative consequences may occur as well. Additional long-term successful adoption and acceptance of ePrescribing is going to require a commitment to upfront training and education of all stakeholders. And the traditional prescribing process includes a number of data transactions, both manual and automated, among a number of entities. So striving for a streamlined, end-to-end, interoperable flow of information in real time requires careful coordination, collaboration, and ongoing education amongst these stakeholders. You'll hear next from two of the pilots about their unique experiences in testing these standards and the lessons learned. We're at a turning point, yet not quite all the way where we need to be. CMS continues to have a critical role to play to ensure that we reach our final destination. The result will be a better patient care, improved efficiencies in both prescriber and pharmacy workflow, and reduced cost of healthcare delivery and healthier Americans. A set of goals I think is worthy of pursuing. And with that, I will hand it over.
Hi, this is Doug Bell. Am I on? I guess so. Yeah, we can hear you. Great. And I've got slides. Okay, so I led the ePrescribing pilot studies that we conducted through RAND and the New Jersey ePrescribing Action Coalition. And I'd like to thank ARC and CMS for funding us and giving us the opportunity to be involved with this important area. So we felt from the start that there was a lot of industry activity in this area, and it was important to actually evaluate what was already happening in industry to the extent we could, and then and also to build on what was happening in industry for things that for some of the standards that weren't being implemented yet. So we worked with Horizon Blue Cross Blue Shield of New Jersey, which already had an ePrescribe program in place and was on the way toward enrolling 1,000 physicians. And I'm actually just going to try to use the pointer here a little bit. So they actually they paid for the installation of ePrescribing, and they paid physicians an honorarium to actually use the system. It was a modest honorarium, but the intent was to stimulate use. And there were 3 systems involved, 3 ePrescribing systems: Caremark's iScribe, Allscripts TouchWorks, and Instant DX's on-call data system. And those are all standalone, handheld ePrescribing systems. Other partners in our coalition were RxHub and SureScripts, the major intermediary companies for passing ePrescribing transactions, and the consulting firm Point of Care Partners, UMDNJ, and then RAND. We were all involved in leading and evaluating this study. So we wanted to work from a strong conceptual model because what we're trying to evaluate is the structure of a technical standard, but that's many steps removed from the ultimate effects that we really care about, which is changes in drug use and other effects on, say, the labor in the physician's office and other health services uses and whatnot. So you have to think through the intermediate steps of how the structure of the standard actually changes something that the prescriber can see at the time of a visit, and then that changes the work processes for prescribing to produce these effects. So we actually developed a workflow model to try to explicitly model some of this, but I'm actually going to talk more about that in the next talk. So for this, we're going to focus mostly on the structure of the standard and some of the more technical level issues, and also on what the prescribers perceived. So just to elaborate on that a little bit, here's an example of how we thought about medication history, which and what the expected benefits of that would be. So as Shelley mentioned, it's a way of getting the current and past medications that a patient has received from an external source that would theoretically be complete, and that's usually the health plan, although SureScripts is now providing it based on retail pharmacy receipts as well. But but it's a way of downloading the complete listing of what has been filled in the past. And then theoretically that could be used for safety checking, for more complete drug interactions and therapeutic duplications. And just the physician could potentially use it manually to review what has been tried in the past by other physicians, and then make more informed decisions. So we wanted to evaluate ePrescribing without medication history transaction, and then compare that ideally to ePrescribing with the medication history transaction. But we weren't able to structure that kind of a study. That's not really practical in a live environment where this is already working. But we still wanted to think through what would happen if you could only, without medication history, you could only check drugs based on what you had already prescribed, what you had prescribed electronically, if you're the prescriber, versus if you added medication history in, you'd be able to include other prescriptions in a more complete medication list. So that's just sort of the theoretical framework that is important to interpret what we'll be seeing. So here's an overview of all of the standards that we evaluated and the really panoply of methods that we used for each standard. And we're not going to have time to go into all of these. I highlighted some that are particularly relevant, and I'll try to touch on today. But just to show you, the two standards here, medication history and formulary benefit, as I mentioned, were already in place in the systems that we evaluated, whereas the others here were not, and we needed to go beyond what existed to evaluate them. We had a technical expert panel to really focus on the technical level of whether the fields were adequate and whether the data that was being delivered was usable. We had site visits to physician and pharmacy offices to interview physicians and do observation of their work practices. We did an analysis of claims data before and after ePrescribing, but that I'm not going to talk about today. That's going to be in the next talk. We surveyed physicians about their perceptions of ePrescribing, and as you'll see, that survey applied to multiple of these standards, and we will be going over to those results. And then for RX norm and structured and codified SIG, we did more of a lab evaluation, which I'll go into a little bit more as we look at the results. So moving along, the technical expert panel consisted of representatives from companies. At RAND, we've done many expert panel studies, and typically we try to recruit experts who sort of just represent their own expertise. But in this case, we felt like the expertise needed to evaluate the technical side of these was really distributed among multiple people at each company. So we had one point person from each company, but that person was asked to talk to everyone within the company or any experts within the company who they needed to answer the questions that we were posing. But we had representatives from point-of-care software vendors, from 5 of them, actually 3 that were in our coalition and 2 others, so that we could get a good mix of both electronic health record and ePrescribing standalone systems. And we also involved the content providers for State of Bank and Wolters Kluwer, 3 intermediary companies, and a range of pharmacies, including both mail order and a large chain, and a software company, QS1, that works with independent pharmacies. So we also, just to give you a little bit more about the other aspects of the methods that I'll be showing you, for site visits, we went to 12 sites where ePrescribing was scheduled to be installed, and conducted interviews before and then after the ePrescribing installation. And then just to give you a really quick introduction, out of those 12 sites where we conducted a pre-ePrescribing site visit, 2 of them actually wound up canceling their installation. Two wound up stopping their use. They did install, but then they stopped using it entirely. And then at 2 others, the staff were using the system pretty much just for renewals, and the prescribers had stopped using the system. But I'll be going into those results in a little bit more detail. Then for the web survey, we started with 395 eligible physicians. 58% of those completed an online survey about their perceptions of related to ePrescribing, and out of that, there were 189 ePrescribers and 89 people who were actually recruited from the ePrescribing waiting list. We wanted to pick a control group who would have equal levels of technophilia, essentially, so people who at least felt ready enough for ePrescribing to sign up for the program, but they had been put on the waiting list. So that's our comparison group there. Now, moving into the results related to specific standards. For medication history at the technical level, this is results from our technical expert panel, we found that the technical problems were really hindering the use that you would want for medication history, which is to basically reconcile automatically the data that's pulled into the point-of-care device with the prescriptions that were generated from the point-of-care device. And that really wasn't happening very much. And the reason for that was that no data was available for many patients because for the medication history transaction to work, there had to first be a successful eligibility transaction so that the patient could be identified, and that often didn't work because some patients aren't insured and other patients there's identification problems. The drug is often not identifiable, and this is a particular problem because of NDC codes. And I'll just mention that there can be 100 or more NDC codes for the same drug, and with the NDC codes, with the sort of math that exists in NDC codes, and it's pretty well documented. There's a GAO report on this from last summer. It's very difficult to map NDC codes, especially across different drug database vendors. So this made it difficult to identify the drugs and reconcile them. And then many other fields in the medication history standard, although they existed, were optional, and they were often left empty. So things like that could really be helpful for reconciliation, like the prescriber's identifier or the SIG or the quantity dispensed, were not always provided. So that meant that the vendors found it hard to reconcile medication history, and so they really just drove alerts for the most part. Some did really attempt to reconcile, and some didn't. But in general, it was the vendors were driving alerts from the prescriptions that they originated. And all of them enthusiastically supported RxNorm as a potential solution for solving problems with mapping NDC codes. We'll talk more about that when I get to RxNorm. Now, at the level of prescribers for medication history, we found that many prescribers were unfamiliar with the medication history feature. In general, the systems did, even though they didn't try to reconcile, the systems that we were working with in New Jersey did present the medication history. So physicians, if they knew how to find it, could drill in and look at the prescriptions that had been filled outside. But not all prescribers knew about this. In fact, in our survey, 37% of the prescribers, only 37%, said that they were familiar with how to access the outside medication history. And then even of those, only 16% said that they used it often or very often. And then we asked them more of a general question about whether the information they have about medication history is adequate, and we posed it this way: information I have about medication history enables me to identify clinically important drug-drug interactions. Well, here we did find a statistically significant difference between e-prescribers and non-e-prescribers, but that is because, most likely because the drug-drug interaction alerts that existed were being driven by the prescriptions they wrote. So it didn't really depend on medication history data. And the other things that might be more dependent on medication history data, like identify medications from other physicians, we really didn't see a difference between e-prescribers and non-e-prescribers. So overall, we felt like medication history was not really fulfilling the promise that it would have for automated reconciliation. Now, moving on to formulary and benefit. At the technical level, again, we found that the NDC codes were a poor drug identifier, which led to huge files and often mismatches between what a physician was prescribing and what was represented in the formulary and benefit file. Another major problem was that the standard doesn't really represent the group level coverage, and it's arguable whether it's even possible to represent that in the formulary and benefit file the way it exists today. So typically it's plan level coverage, and the problem is that individual patients have contracts, group level contracts, where the formulary benefit may vary slightly. So the plan level coverage may not be perfectly accurate. And then out of the major components that exist within the formulary benefit standard, one, the formulary status list is widely used, but the other components that provide additional details, like alternative suggestions, coverage limitations, copay information, are not being used nearly as much. And there's another file called the cross-reference file, another component that could be potentially helpful, and really nobody was using that at this point. Now, moving on to prescriber perceptions, people had a range of opinions about the formulary benefit information they had. Some, this is from the qualitative results, some did perceive it as accurate, others did not perceive the information as accurate. Overall, when we asked about the benefits of formulary and benefit, people were fairly neutral on average. They did say there was a trend toward more agreement with the drug coverage information that they have helping them manage patient costs, but not really much on the other things that we were hoping for, like reducing the need to change prescriptions later, reducing calls because of coverage problems, saving time overall. On average, both the e-prescribers and the non-e-prescribers, I'm sorry, this is just e-prescribers answering this question. They didn't really perceive a lot of benefits from the e-prescribing formulary benefit information they received. And this is a little bit more on that. This is from the survey, again, asking non-e-prescribers versus e-prescribers how many calls or messages they were getting per week, and how much time they spent dealing with those calls. And overall, we didn't see really a significant difference that would be attributable to e-prescribing. And I'll just move on in the interest of time. We can come back to it if people want to dissect those results. Moving on to fill status, our technical expert panel found that, well, the biggest thing is that they really didn't think that there was a marketplace demand for the fill status transaction. A quote from a panelist is that even if a physician wants it, who's going to pay for it? And they thought that there could be a lot of burden from handling opt-in and opt-out requests. And there's some potential privacy issues with the fill status transaction, because if a patient, let's say, severs their relationship with a physician, they could conceivably still be getting fill status transactions, and other patients might want to, either opt in or opt out of their physicians getting that information. But a panelist said the process of setting up and maintaining opt-in or opt-out indicator would be significant. because it would need potentially that information, the opt-in or opt-out information, would need to flow back to the PBM. So that could get very complicated. But others thought that it could be dealt with. A panelist said that's something that can be designed for, and I think that having a patient opt-in or opt-out of this is probably something on which we should do more research. There was also a technical issue with the accuracy, with how fill status is implemented, whether you're going to send information about whether the medication is either dispensed, or are you also going to send information if a medication is not dispensed? And should it be one way or the other? Either one can be handled right now in the fill status standard. But panelists pointed out if patients are opting in or opting out, then if the physician doesn't get a filled response, what does the physician know? Maybe I opted out. So there are some ambiguities that potentially need to be worked through. We did also talk to prescribers. We conducted focus groups to evaluate whether the information they could get from fill status would be potentially useful. We actually worked just with Allscripts on this, and they created storyboard prototypes to illustrate what could be done with adherence alerting. But the prescribers expressed significant concerns. They said getting this kind of information implied that they would have to telephone the patients to follow up, and that creates new unpaid work for physicians and staff, and potentially even medical legal liability, although that's potentially arguable whether it would really be different from the medical legal liability they have today. But they did point out some possible mitigating factors. So if the prescriber could control which prescriptions would receive fill status alerts, and what the time interval would be before an alert would kick off, that would be potentially helpful. And I'm just going to move on in the interest of time. Now, for prior authorization, we actually created a working prototype with Allscripts and with Caremark iScribe, and rolled it out to a group of users in New Jersey for each product. And we also conducted surveys to ask, actually we asked all prescribers in our survey about prior authorization, and also we discussed it in our site visits. And first of all, there was a strong demand for electronic prior authorization. People did think that it could improve the process, and there was a lot of frustration with prior authorization the way it exists today. And some choice quotes were, I hate prior authorizations because of the time they take. Basically, you have to say what the insurance people want to hear, and one prescriber said, I frequently lie, yell, or scream. So they did perceive this as taking inordinate amounts of time. So as I mentioned, we developed prototype modules and rolled them out. But we found in this development process that few of the data elements that existed in the standard that we were supposed to evaluate, the HL7 prior authorization attachment, which is really the core element of the standard that carries the prior authorization data, really few of the elements that had been prescribed for us to use in that standard really fit with Horizon's prior authorization processes. And the issue really came down to the fact that it's the wording of the questions that are asked of the physician in the prior authorization process is really important to understanding what the meaning of the data is. And the HL7PA attachment didn't really specify the wording. They specified sort of more abstract data fields that didn't really match that well with the data that Horizon really wanted to collect. We can discuss that more too in the Q&A if people are interested. And I think the other thing to mention is that even though we rolled this out and made it available for 8 to 10 weeks before the end of our pilot project, we found that there was very little use of the electronic prior authorization modules. And overall, there wasn't that much prior authorization taking place. It had actually declined. The prior authorization volume overall had declined from the previous year a decent amount. So moving on to RxNorm, we evaluated, we conducted a lab evaluation to just look at the completeness and accuracy, essentially, of representing a large sample of prescriptions using RX norms. So we worked with First Data Bank and Metaspan, and then we at RAND actually also did an independent match attempt. And the idea was just take the sample of prescriptions and see if we can match to an SCD, which is really the unique identifier in RX norm, for new prescriptions and for renewal prescriptions. And I should just mention that the idea of RX norm really is to have one unique identifier for a drug, dosage, and dose form combination. And that's what the SCD is. It's a semantic clinical drug. And so for, say, for a prescription of lisinopril 10 milligram tablet, there would be one and only one unique identifier for that concept, and all of the NDC codes that exist for different lisinopril 10 milligram tablets from different manufacturers would map to that. So we took a sample of 10,000 prescriptions, and we found that there were almost 9,800 non-device prescriptions. We just focused on non-devices, and basically 1.5% of those we found no matching SCD. So that means that 98.5% had a matching SCD in the RX norm version we evaluated, which, by the way, was the one from November 2006. Then we also looked at renewal requests and found that actually 99.5% of those had a matching SCD, so actually a higher percent. But we also looked at mismatches. So in some cases, these different independent attempts wound up matching to different SCDs, and that basically happened in about 5% of cases overall. So in a way, that's actually a bigger problem than the incompleteness. And when we drilled in on the root causes of that, there was some synonymy that was previously unrecognized, and that the RX norm people actually corrected based on what we found. That was about half of the cases overall. And then there were some errors that we made, the individual matching efforts. Probably the other half was basically errors in our setup to match the RX norm codes. So that's it for RX norm. Finally, structured and codified SIG. So here we actually just did a purposive sample of 42 prescriptions out of actually starting from the same 10,000 sample that I just mentioned. And the reason we only used 42 is that this had to be a manual process, and the structured and codified SIG standard had actually just been completed a few months earlier. So we worked with 3 independent, actually a total of 5 independent reviewers, but each SIG was mapped by 3 separate independent reviewers. And we tried to map it, basically manually map it into the standard. The thing about the SIG standard is it has a lot of fields. It has, I believe, this is a listing of the segments within SIG, and each segment contains multiple fields. So there's on the order of 100 separate fields in the SIG standard. And then if the SIG contains more than one, well, they call it a repeat. I guess I won't get into that, but if it contains more than one repeat, you're supposed to actually repeat this whole list of segments. And out of the 42, only 15 of them didn't use a repeat, and it was harder to look at the agreement among these 3 independent reviewers if we had repeats. So first we just looked at the 15 SIGs where no one used a repeat to represent it, and we found very little agreement among the reviewers in how they represented the data even within an individual segment. So for instance, for the dose segment, out of the 15 prescriptions that we represented this way, in only 3 cases did all 3 of the reviewers represent the data in the same way within the dose segment. And in 10 cases, there were 2 out of 3 did it in the same way, and in 2 cases, none of the 3 reviewers used the same representation of the data. So overall, there was really poor agreement in applying this among our reviewers, and I'll just end with that. We can go into this in more detail if you'd like. So in conclusion, we found that the medication history and formulary benefit standards were technically adequate, but falling short, especially due to NDC code problems and other implementation problems. For fill status, there were significant concerns both among the industry people and among prescribers about the functionality that it really delivers, but we did think it had some promise for focused uses. For prior authorization, we really need more research on how to represent the data for prior authorization decision making. For RX norm, we found that there's really a strong need for it, and it does hold significant promise, and just a little bit more work and more research is needed to figure out how to finish it and start using it. And then for SIG, we felt like it was, the way it exists now makes it difficult to use consistently, and our suggestion was to try to simplify it. So that's it.
Thank you, excuse me. Thank you, Doug. This is Mike Bordelon. Appreciate getting an opportunity this afternoon to talk about the long-term care ePrescribing pilot study that was performed last year. I was the principal investigator on this study, and it's really kind of an exciting study, I think, personally for me, but also for the long-term care industry, and I think the healthcare industry in general. If you step back and look at what we did here, it's really as much as a study about the standards as it was an existing proof for us to show that ePrescribing really was even possible in a long-term care setting. When I say long-term care in this context, long-term care is actually a pretty broad segment of the healthcare industry. It can include everything from independent living, assisted living, skilled nursing, hospice care, home health, all those kind of settings. Where we focused in is the more traditional long-term care setting, which is the skilled nursing facility, with typically a Medicare and a commercial and Medicaid mix of census in the facility. Our study. So if you look at the 5 studies that were done, our study was the only one that focused in the long-term care setting. And this presented a pretty big challenge to us. The slide that's in front of you is about 2 years old, and quite a few people, I think, have seen it at this point. But it's really been a good way for us to demonstrate some of the challenges that the long-term care industry faces with prescribing in general, but also with implementing ePrescribing. One of the things we learned really early on is that you can't just drop in a traditional ambulatory ePrescribing software system and have it work in long-term care. The workflow is different, just basic things like orders not having end dates, and some of the signature rules and some of the workflow back between the nursing staff and the pharmacy and the physician creates some differences that aren't always applicable in the ambulatory world. Some of those key differences are again the 3-way communication between the prescriber, the nurse, and the pharmacy. There's less dependency on the physician using the system because you have a nurse that's kind of brokering the communication between the physician and the pharmacy. That the nurse can act as an agent and offload some of those prescribing duties. There's also heavy use of nurse practitioners and physician's assistants in long-term care, which helps reduce some of the dependency on physician adoption. Most orders have no end date, as I mentioned before, or quantity. Refill requests work a little bit different than in the ambulatory setting. What will happen is you get to the end of a cycle fill. For instance, you get to the end of a 30-day cycle, and the nursing home, through some mechanism, whether it's through fax or a phone call or something, notifies the pharmacy that they're out and they need a refill, and the pharmacy sends over more medications. That's different than the renewal process in the ambulatory setting. And then we have the way that Part D and Part A and even Medicaid is billed in the long-term care setting can often be a little different than what you'll see in other settings. And then at this point, there's really what we found as we were getting into this is how little infrastructure or applicable infrastructure was in place at the pharmacies, at the facilities, for the doctors, for anybody in this mix. And so we were really faced into a very unique situation at the beginning of last year when we finally came to terms with what we had committed to CMS and ARC to do to actually pull together a full technology infrastructure to test long-term care for the first time. So what we decided was, instead of going for a lot of volume and trying to get a whole bunch of doctors and a whole bunch of nursing homes up and running, we decided to focus in and just focus on the standards that we thought were most relevant to long-term care, focus in on just 2 nursing homes, one that was a little bit more urban setting and one that was a little bit more rural, that would give us kind of and different acuity levels, that would give us a kind of a broad view without having to do many implementations. And we also had to carefully select the providers that were going to be involved to make sure that we had people that were going to really be able to push the envelope in this very compressed time frame that we had last year to get this rolled out. So when we took a careful look at the standards that were applicable to long-term care, it was very clear that we needed to test the script of communications, specifically with the new RX, but also to use the CanRx for canceling orders, because remember, they don't have an end date. At some point, a doctor's going to say, "Continue this order," so that it can be so that it'll stop at the pharmacy. Also, we wanted to get a message coming back from the pharmacy to the nursing home to tell them the status of a medication. So we implemented fill status, and we also implemented the change messaging. So if let's say the dosage or the frequency of a administration for a medication was changed on an order, we implemented that change message so that would be handled at the pharmacy as well. All those were really relevant, and I think we actually pushed the envelope pretty far beyond what you'll see even in the ambulatory world with just implementing the new and fill status messages by doing the cancels and the changes. We brought Blue Cross Blue Shield into this project. I'll flip forward a couple slides. Blue Cross Blue Shield and Prime Therapeutics were involved in this project. They're down here, and they had a pretty large presence in the Minnesota area where we were doing this study, and were able to get our formulary and benefits coverage up, in some cases as high as 50%. And so we were able to really effectively study the formulary and benefits. We got all the infrastructure in place. We were able to test. We built the technology so that we could test formulary and benefits in line while the prescribing process was happening, so we could really study how that worked. And then through some additional funding that we got from the American Society of Consulting Pharmacists Foundation, we were able to also study a prior authorization, and this was a fully implemented technology infrastructure that had communications all the way back to Prime Therapeutics, bidirectional, so that we could get real-time information on prior authorization. Similar to what Dr. Bell was talking about, unfortunately we didn't get a lot of volume there, and I'll talk to that in a minute, but we were excited that we were actually able to get the full technology infrastructure in place and do some real end-to-end transactions. We also found that that there were some other things that while we were doing ePrescribing, we needed to test these things because at least the provider that we were involving, Benedictine Health Systems, felt that they were very relevant to any ePrescribing system in long-term care, and would, if we didn't do them, would significantly degrade the value of the system. And so we had to implement a refill process because 80% of the ordering that goes back to the pharmacy are refills. We also had to implement a DUR patient safety check on the front end. We did that using a First Data Bank database integrated in, and so in real time we're doing DUR checks, formulary benefits while we're placing the order and doing online substitutions and those kind of things. So some pretty exciting and pretty advanced ePrescribing concepts were all implemented all in this integrated workflow. We also needed to implement signatures because of the regulatory nature of long-term care and a lot of the signature requirements that are imposed on the nursing home. We needed to layer on top of this some signature capture capabilities to make sure that we kept the LTC facility in regulatory compliance. We did not, for a couple reasons, time, dollars, and then relevance, we did not get to do anything with codified SIG, medication history, or RX norms. Hold on, let me move forward one slide. Quick high level on our facilities. You know, we would have loved to have done this in 30 or 40 or even 100 nursing homes, but like I said, we didn't really have the time last year to do more than to really implement more than 2. Now we had 4 total facilities in our test. These 2, this test facility A and test facility B, were where we actually implemented the ePrescribing system, and those both talked to the same pharmacy. In fact, all 4 of these sites use the same pharmacy. So we were kind of normalized on the pharmacy as far as the pharmacy providing the same services. We had 2 other facilities that were also in the Minneapolis area, and they were using traditional paper-based systems, faxing, phone calls, those kind of things that look very typical to what you'll see in any normal nursing setting that you'll go to. I think one thing that's interesting here was between our 2 test facilities is one was a very rural site that had a very traditional, pretty low, I think it was 15 to 20% Part A census, and then on our suburban side actually was a much more acute setting. It almost looked like a subacute hospital. It had very high Part A census, and that let us test different kinds of sites that had different admission and discharge rates. At the suburban site, we would have much higher turnover rates in the facility, and we got to see the benefits of having an ePrescribing system that, and saving the time during admission and sending all of these orders over and that kind of thing in a much more aggressive way than you see in a typical long-term care setting. Without getting into the details, I want to just point out some of the technology infrastructure that we had here. We used Achieve's ePrescribing system, their computerized physician order entry system that was tied in with their electronic healthcare system that was already implemented at both of the facilities. The nursing station communicated back to that system, as well as the physicians and nurse practitioners that were participating. That all went through the RX Hub switch to both the payers for formulary benefit information, as well as to the pharmacy system that was hosted by the pharmacy, and the pharmacist and the billing and the folks and the pharmacists at the pharmacy use that system. A unique thing that I talked about that we implemented is this refill request scanner. This is a proprietary system that we wanted to implement to demonstrate the use of an electronic refill capability. It was a handheld scanner that is on the med administration card at the facility, and it was used to basically scan medications that were low or about to run out to automatically queue up the refill process. So let's jump into some of our findings. At the facility, we first of all noticed, especially at this facility where they were already using some basic electronic health record and order management capabilities, that this was not a huge leap for them to to make a transition from that to full-blown ePrescribing. Now that said, they were using an electronic order management system at the facility already. So I think if you took a paper-based site that had no technology infrastructure in place, you would obviously have a much greater transition to an electronic capability than these two sites that we implemented had. We found that because they had that electronic health record in place, that integration back to that health record and all of the benefits you get from having the consolidation of all of your clinical information in one place, having it accessible by so many people was a huge benefit to everybody that was involved. We did find that in general the time it took to transmit the data to the pharmacy reduced the workload on the facility personnel, but that was mostly due to reductions in rework, phone calls, callbacks, those kind of things. It was less about the initial data entry, because in some cases we actually added more work to the nursing staff, because in the past they may have just taken a discharge sheet from the hospital where the resident was coming from and just faxed that on to the pharmacy, and now they're having to enter that into the CPOE system. We did find in the cases where we could get nurse practitioners to get involved, that was a huge benefit not only to them because they had the formulary benefits and DUR information available at their fingertips, but we also found that it saves a lot of time for the nursing staff because now they're not in the middle of the processing at all. So that's really the ideal place for us to get to, and unfortunately we didn't have enough time to watch that full evolution to see all the prescribers in the facility participating in the electronic prescribing. At the pharmacy, we saw some clear benefits almost right off the bat. When a new person was admitted, all their demographics came across. Their data entry on handling new orders was a lot easier. Discontinued orders, the workflow for that was streamlined in a real way. And readmissions, handling somebody that had left the facility and came back, and we electronically tell the pharmacist that this person's been readmitted, and all their orders come back and are available for dispensing. Were huge efficiency gains. We did find, and this is ironically, we chose not to do the codified SIG, and we did find actually that hurt us in many cases. Actually, the first day of prescribing, we had a compound order. It was a tapered dose of prednisone, and the system couldn't really handle it well. And in the old days, it would just be kind of handwritten over, and the pharmacy kind of knew how to fill that, and there were special rules on how to do that. Well, when you make everything electronic, the systems have to handle all of the weirdo border cases as well as the mainstream stuff, and certainly codified SIG or something like it is going to be needed to make handling these combination orders or complex orders successful. We had another case where now we're more dependent on the nurse at the facility to enter the correct data, and we had some cases where they had made some mistakes, and we didn't necessarily remove all potential data entry errors. I think we just moved where they can happen to the nursing home instead of at the pharmacy. Although we do believe that we saw a dramatic decrease in total errors. And then finally, when somebody gets admitted, like I said, in the old days, someone would just turn around and just fax the discharge summary from the hospital, and now there's some data entry time that needs to happen either by the physician or by the nursing staff, and that can slow things down before the pharmacy gets their first round of orders. So what we did find is that the nurses and agent model works for the process. It's a good way to introduce ePrescribing to a facility without having to leap all the way in and get all your doctors and nurse practitioners transitioned over. But as soon soon as that happens, we need to turn around and push really hard to get the prescribers actually using the systems because that's what's going to get us down to the error rates where we need to be, and it's also going to help us really attain the efficiencies we need to get to. The leadership at the facility, at the pharmacy, and with the prescribers is absolutely critical for success. If you don't have everybody behind you, the project will not be successful. We had amazing leadership at our provider and at our pharmacy, and we believe that was a huge element of us being able to get this implemented. We believe formulary benefits technically works unchanged without any changes to the standards. We think that, again, prescriber adoption is going to make it more valuable. The nurses don't really know what to do with that information if they get a formulary benefit flag that that a drug is not on formulary, and so it's important to get that in front of the prescribers. We found that all that DUR work that we did, the drug utilization review work with First Data Bank, was largely ignored by the nurses when they were acting as an agent. Again, we believe as more prescribers start using the system, they'll see that as more valuable. And our electronic prior authorization implementation was technically successful. We did prove that it can work, but we only had a handful of EPA requests to actually go through the system. And again, we felt like greater physician adoption would be necessary to gain the full effect. So at a high level, kind of summarized here, we believe that data entry errors can still happen. We also found that the script standard needed some enhancements. We worked the process at NCPDP and got those enhancements made for all the different workflow models, and we believe the standard is now in line with the needs of LTC. We did find that there's a need for demographic messaging, a specific message set to handle moving demographic data back and forth. That has been in process at NCPDP and will be available to support this setting. And we think that codified SIG or something like it is going to be needed to really make the ePrescribing processing support all the different kind of orders that are out there. This last couple slides, let's see here. I want to cover all this. Okay, so a couple other data points here. So multi-system communications works technically. The ePrescribing will continue to evolve as the standards are designed, but we believe that the core concepts are valid. We did identify some new challenges created by ePrescribing process that are going to require some resolution. And the standards still needed some revisions for long-term care, but most of those changes have been approved by NCPDP or are in the process. Now I'm going to go ahead and stop there, Andrew.
Mike, this is Brian. So you're done with your part. You want to transition to questions?
Yeah, let's go ahead and do that.
Okay, let me bring the other presenters back online here, and we'll just move to the end. So, good afternoon. This is Brian Dixon from the ARC National Resource Center for Health Information Technology. We're now going to segue into questions and answers with our panel. John White, unfortunately, did have to drop off of the call, so I'll be moderating this afternoon. We do have Drew Morgan from the Centers for Medicare and Medicaid Services on the line with us to help in answering questions. So there's two methods that you can use this afternoon to ask questions. The first one is you can raise your hand, and if you look in the participants box where you see your name, there's a little hand icon down below your name, and you can press that once and raise your hand. Pressing it a second time will lower your hand. The other method would be to type into the chat box your question. I ask, though, that if you use the chat feature, that you make sure in the little drop-down box where it says send to, that the value for that is all panelists. That way, Drew and Mike and Doug and Shelley can all see your question at the same time. And I'll help parse out questions
but it looks like we have one person who's raised their hand. So let me go ahead and call on Edward. Edward, are you there?
Yes, I am. I'm with the New York State Department of Health Patient Safety Center, and we've been looking at the issue of ePrescribing, and I'm glad that you brought up the issue of RX norm in terms of a unique identifier. We're looking at the issue in terms of ePrescribing, in terms of when the prescription is filled by the prescriber, it goes to the pharmacy, and unfortunately, it goes either as an electronic email or a fax, and oftentimes someone at the pharmacy then needs to data enter that information. The question is, did either one of your studies look at the use of RX norm to help populate the pharmacy system with the electronic prescription rather than requiring data entry? And if the answer to that is no, are there any research studies proposed to do that?
I guess I could field that, or Shelley could conceivably, if you want to go across them. But what I'll say is that we did do some pharmacy site visits, and we didn't specifically look at RX norm, but some pharmacy systems, and I think more and more, are doing some automatic population of even without RX norm. RX norm is not really being used extensively yet in the industry. I think they're still hanging back a little bit, is my impression, to see what happens and to wait for it to become even more accurate and complete. Regardless of that, the systems are doing some automatic population, but there still does need to be a pharmacist sort of judgment in the loop as well. And often there is a second data entry step that does introduce the potential for error, as you say. So hopefully that helps a little bit. But more research is needed. I mean, on the RX norm piece, I think a little bit more research is needed, and more awareness needs to be raised as well within the industry.
This is Drew Morgan from CMS. We realize that the RX norm has the capability of doing some great things, and from this pilot, we have been in dialogue with the National Library of Medicine to see what we can do to move RX norm along so it can be used in prescribing. Thank you.
Thank you for your question. Again, if you want to raise your hand, you can do that and ask your question verbally, or you can type in your question to the chat feature. Looks like there are a couple questions here that have come through the chat. So one attendee, excuse me, and I'll direct this towards Doug because I think you talked a little bit about this, but he asked, will you be able to discuss what level of honorarium or incentive might be required to initiate and sustain prescriber use of ePrescribing, assuming the software and hardware needs are already provided for? I think you had mentioned you did use such an honorarium for participation, at least in your surveys.
Right. Well, okay, the survey is a different thing, but yeah, just for use of ePrescribing Horizon, this didn't come out of our grant. This was already being done, and it's still being done by Horizon. The range is $150 to $500 per quarter is what Horizon is using based on how much you use it, what percentage of all of your claims seem to be coming through the ePrescribing system. And 100%, of course, is not necessarily achievable because DEA Schedule II drugs can't be electronically prescribed. But with that said, use is a really important area to do more research on, and we hope to have the chance to do more research on that, in fact, and we'll be talking more about the results that we have in terms of what predicted levels of use and what were the levels of use really in the next presentation.
Great, thanks, Doug. I know one question I had too is if you could maybe elaborate on some of the activities you may be involved with now in terms of moving forward. I know several times during your presentation you talked about the need for more research in certain areas, and I didn't know if you were personally working on any of those areas to move them forward.
We're trying to, but so far we haven't had a lot of success in getting funding. So I'll just leave it at that. We don't have anything active at the moment. We've written proposals, and we think there's hope. For instance, you may have heard that SureScripts is setting up a Center for Medication Management along with a coalition of other companies, and they plan to fund some research. But that'll be a competitive process as well, and they're just getting that going.
So I'm reading. Yeah, no, thanks, Doug. I'm reading some of the questions that have come in here. One question for the panel is how folks are handling classes of drugs that cannot be e-prescribed today. I don't know, Shelley, if you want to weigh in here, and Doug, you certainly can as well.
On what classes of drugs?
It just says the classes of drugs that cannot be prescribed today. The person was not specific in what classes. So maybe those are the.
This is Drew Morgan. I think what they're asking about the controlled substances that right now are not able to be prescribed. Last year, HHS and DEA held a public meeting to discuss this over 2 days, and we are currently still working with DEA to try to help them along with maybe revising the law that oversees the Controlled Substances Act. So we are in communication with DEA and hopefully something that can change in the near future.
Thanks, Drew. Another question from the group is, what are the prospects for an update to the structured SIG plan that would work better?
This is Drew again. Currently, the NCPDP work group that works on the codified SIG has submitted a DERF to NCPDP, and I believe it's under ballot right now. So they have made some changes to it, changed the way it's been the standard works, and so what happens after it gets balloted? Hopefully, there will be some pilot testing on it to see if it works or what needs to be done to tweak it.
Thanks, Drew. Another question is if any of the panelists can provide an approximate time frame for when these initial standards will all be finalized. It sounds like there's several things in process and ready for release.
Well, this is Doug. Shelley, you might be able to comment, but I believe the initial standards are supposed to be issued by the Secretary middle of next year, right? Or Drew, you probably know.
Yeah, currently from the findings of the pilots, we are to take the recommendations from the piloters, and we're to form another NPRM that lists what standards that we're taking forward out of the 6. And that NPRM will be out later this fall, and there will be a 60-day comment period from those who want to comment on the NPRM. And by April 1st of next year, the final rule will be released, and that's the timeline on it right now.
Have there been any major shifts, Drew, since you all received the reports from these guys in terms of, policies? There's some discussions in the work about changes or funding for additional research that these guys identified?
Not that our office doesn't have any type funding, but we've been talking to folks trying to leverage certain pilots that are already ongoing, or we've been working with ARC to try to move some of this work forward. So yes, we have been trying to move some of the stuff forward that needs work. But other than that, not currently right now. We're just kind of like in the planning phases.
thanks. Another question for the group is, I know, Doug, you talked about this, about prescriber satisfaction with the process, which was somewhat indecisive. I'm wondering if you also talked to the pharmacist and kind of what their response was.
We did, just qualitatively, and we only did 2 pharmacy site visits, but they were generally enthusiastic about ePrescribing and about the potential efficiencies. And some of the things that we were concerned about, like there might be a higher rate of no-shows, essentially, like people whose prescriptions would be sent over and then they would never show up, which would potentially generate some work. It wasn't really materializing that people do tend to show up when their prescription is sent. And there's some thought that it might even be a higher rate than the people who get a paper prescription and never fill it anyway. In other words, that the process of having the prescription sent might actually make people feel sort of more obliged to fill their prescription. So pharmacists tended to like it, and also just in terms of prescriber satisfaction, I should mention that overall prescribers were pretty satisfied with the ePrescribing systems, at least those who hadn't quit using it. But what I was showing here was just more focused on specifically medication history and formulary and benefit. And in those areas, people did feel like it was still falling short.
Great. For those of you who are online with us, thank you again for sticking around for the Q&A section. We've got a couple more questions to get to, but we are getting close to time. I'm going to start in the background a post-session questionnaire. If you could just fill that out before you log off today, the Art Resource Center would really appreciate that. We really look at this feedback and use it for improving these sessions going forward. So I'll fire that off in a second. And so just please be sure you fill that out before you log off today. Let me unmute Mike so he's back with us. One question, or 2 questions really. One is for Drew, and that is one of the listeners kind of had a hard time catching all the dates for the plan moving forward. So is there a URL or some information on the CMS website that people could find to follow along the path of the plan moving forward with these?
Are you talking in aspect of the MPRM in the final rule?
Yes.
On the CMS website, there is the ePrescribing page, and I don't have the URL quite handy. But if you go under Medicare and under electronic prescribing of the CMS page, there's a section on ePrescribing. It outlines what we're charged to do through the MMA, and also we also provide links to all the pilot reports and to the evaluation report as well. So you can, in any time that when the MPRM will be posted to the Federal Register, there will be a link provided there as well.
Great. Maybe if you send that to me offline, I'll include it with the follow-up email that goes out to the attendees.
I sure will. I'll send that right to you.
Great. And also from the resource centers, and we'll also send out some information that's available on ARC's website with particular emphasis on sort of prescriber use and adoption. There was a study that ARC funded also last year, and the results of that have been posted through Health Affairs, and there's a free link via the ARC website. So I'll make sure everyone gets a link to that in the follow-up email. Just quickly, if the folks can comment, especially Doug and Mike, one attendee asked about sort of the HITSP, the Health Information Technology Standards Panel, has presented the use case for medication management, and how the findings from your studies and the others in the ePrescribing pilot might be included with that 2006 use case.
Well, if that's directed at me, I guess we're going to have to look at that more carefully.
Yeah, I'm not up to date on what's on the use case, so unfortunately I don't have an answer.
All right, thanks, guys. Well, think that's about it. I do have a URL that we can actually push out now to all the participants from someone else from CMS who's on the line with us today, but just not part of our panel. So I just pushed that out to everyone so you can use that, but we'll also include that in the follow-up email. And those are all the questions that I see on my screen. Is there any final comments from the panel before we wrap up today?
I thank everyone for attending.
Yeah, this is Doug. I did see there was one last comment that just came up there asking why half of our sites dropped out. It wasn't quite half, and it wasn't, I just wanted to say, overall, I think ePrescribing was successful. I probably am giving you a little bit more of a negative opinion than I want people to take away. We were focused today more on medication, I mean specific standards, and this will be a plug for the next one because we'll go into the overall successes and failures in the next call.
Great. Thanks, Doug. And just to remind people, that call will probably be scheduled towards the end of October. We're still trying to finalize a date with all the presenters for that, but as soon as we get one, you'll receive an email with information on how you can register to attend that event. Any other thoughts? Final comments? Well, thank you very, very much to our panel for your time this afternoon, for both the presentations and for answering questions. Thank you to everyone on the line for attending this afternoon. Please fill out the post-questionnaire poll so we can get feedback from you on how today's session went. We will utilize those comments in our quality improvement process for these events, and look for a follow-up email with links to download both the slides from today's presentation in sort of full screen mode as opposed to the handout that was available before the session, as well as a recording of the audio and presentation from today. And now all that will be available via the ARC Health Information Technology website. So thank you again, and have a wonderful afternoon.